Good afternoon and welcome. Thank you for joining us today. My name is Samantha, and I'm the Director of Member and Partner Services for the Florida Association of ACOs. We are excited for this opportunity to present to you our next installment of our webinar series, No Time to Waste, Getting Ahead of Medicare CQMs for ACOs. Before we get started, I'd like to share a few quick notes to help you make the most of your webinar. For audio, if you're currently listening through your computer speakers and prefer to dial in by phone, simply click the small arrow next to the microphone icon in the bottom left corner of your Zoom window. Select the switch to phone audio and follow the dial-in instructions provided. We welcome your questions and thoughts throughout this session. You can submit questions at any time by clicking the Q&A icon on your Zoom toolbar. Just type in your question there. We'll collect them along the way and address them during our Q&A portion at the end of the presentation. Feel free to use the chat box if you're having any technical difficulties. We're here to help assist. Also, today's session is being recorded, and we hope that you will share this with your colleagues. With that, I'm going to turn our presentation over to Derek Pauly.
Thank you, Sam. Good afternoon. My name is Derek Pauly, and I run Blue Sky Analytics. Today, we're going to talk about the comprehensive CQM reporting solutions that Blue Sky has for Medicare Shared Savings ACOs, with a case study of a successful reporting for 2024 from Palm Beach ACO. Just a little about Blue Sky. Blue Sky, we're a boutique analytics firm. We're very experienced in the ACO market. We've been involved in ACOs since 2012. We're a trusted and proven ACO analytics partner, and we power over 20 ACOs, MSSP and ACO reaches. And we have a very easy and complete solution. And the next slide, there's quite a bit here, but we don't just do quality reporting. It's one of the things that we do very well, but we also have a complete financial end-to-end analytics suite, from physician engagement to patient stratification, data integration, and things like that. So in a nutshell, Blue Sky is one partner and one platform that you can rely on with proven results. As everybody knows, there's big changes to quality reporting. They're not going away. ACOs are being stressed by these changes. So we are now over almost halfway through the year. And if you haven't started reporting or closing gaps, it's time to do that. You're already behind, I would say. So reporting is also on all fee-for-service beneficiaries. It's not just your ACO assigned beneficiaries. That's the assignable and fee-for-service beneficiaries as well. And you have to report on a data completion for a minimum of 75%. And of course, this impacts ACO shared savings eligibility. So it's very important. The web interface is gone. And as far as we're concerned, it's not coming back. So it's time to make that switch. So with that, I'd like to turn it over to Amanda Larchon, the Chief Data Officer for Palm Beach ACO, to give a little information on her experience with CQM reporting.
Thank you, Derek. Yeah, great opening. And before I get started, just wanted to give you an idea who from my team is on at Palm Beach ACO. They're here to answer any questions. So please, if you have them, we're happy to connect through the Q&A or offline. Derek as well. TJ will have a couple of slides. He's our VP of Innovation, and Jessica Bailey is our VP of Performance Improvement. And we all worked really hard on quality reporting this past year in conjunction with Blue Sky. Next slide, please. And just a little bit of an overview, just so you know that I focus on quality a lot. I have overseen quality at Palm Beach ACO for many, many years. I oversee the data analytics and our quality reporting, as well as our call center and our clinical department. Next slide, please. So Palm Beach ACO absolutely started in South Florida. And as you can see on this map here, we've expanded into multiple states. But what we're most proud of, and to preface this this presentation is our quality results. Palm Beach ACO takes quality very, very seriously. Our doctors are most proud of the quality scores and quality care that they provide their patients. So there in yellow are some statistics that we're really proud of, averaging 94% quality score since our inception back in 2012. Next slide, please. Okay. So quality reporting. And I was also looking through the list of who's on the meeting, and I met some of you at some recent conferences. And so I know we share this similar feeling. So when you think of quality reporting, like if you close your eyes, right? What's the first thing that comes to mind? And do it, because we could all just use, I'm sure, a quick break. It's been a long week. And the first thing that I do, I just sigh. It's a sigh of relief. It's a sigh that it's over, but it's coming again. It's a sigh of uncertainty as Medicare is changing the rules on us. It's a big lift no matter how you report or who you report with. So it's very important that you start early and you develop a partnership with someone now. It is extremely, extremely important that you don't wait until Q4 to decide who your partner is going to be. That might be some of my best advice. I've done the web interface reporting for 10 plus years. Many of you have. We talked about this together at the recent conferences. We all got used to that process, right? It's hard and it can be a difficult process, but we all got used to it. And so now, unless any rulings are going to change, we're in this new world of Medicare CQMs. And I'd like to point out that I've been doing the web interface reporting with actually Blue Sky for many of these years. And so we've developed a good relationship, a lot of knowledge on quality throughout the years, and we hope we can share that with you through our use case. Please absolutely start now. And why it's so important is we could lose everything as an ACO. I mean, everything we all work so hard to do with our physicians. We don't want to get a check of $0 when you certainly earned it. And that's how important quality is to the Medicare Shared Savings Program. So a couple highlights for me here is Blue Sky and their ability to help with quality reporting. Palm Beach ACO has practices of all sizes and types. We are all independent primary care physicians, multi-specialist groups and specialists, but they may be mom and pop, just, the wife may be running the office and the doctor is seeing the patients, all the way up to huge groups with thousands and thousands of lives and multiple locations across multiple states. Some have no EMR. I know. Does that sound crazy? Some have the best EMR and the best integrations. But what's great about this process is no matter where they are in the life cycle, Blue Sky can help them report accurately and timely. The dashboard options are endless for me. I didn't have a lot of time in quality reporting. We were very busy doing the actual reporting in conjunction with Blue Sky. So seeing dashboards that I can quickly get to, print out, discuss with the team, Jessica and I and TJ, we would meet often to review these dashboards at the practice level, the provider level, and even more importantly, the user level, the work that our quality team was doing, the work that the offices were doing. So these dashboards were extremely user-friendly, which leads me into my next point, that the system in general is very user-friendly. You want to know more, you simply click, it pops open into a new page, and you can drill down as far as you need to get the information that is important to you. Derek will cover this later in the presentation, but there's very important hints and cues. They were an absolute lifeline. So now you use all your integrated data sources, your CCLF, your BCDA, your lab partners, which I'll cover. And then what? You still haven't met the 75% completion, right? What do? They have wonderful queues set up that they use claims to suggest that maybe a quality action could have happened and that your provider should look there. Check that date of service for the documentation. And it was an absolute game changer for us to hit our completion rate with high quality results. And the speed and collaboration that Blue Sky provides us, they are very easy to reach with a quick turnaround time, which there is a deadline on quality reporting. So it's important that we get support that is accurate and timely. And I found that with Blue Sky. And my absolute favorite quote, it might have been from Derek himself when he said, Amanda, we can process only 80,000 patients per day. What do you mean only? That's a lot of patients and a lot of patient records. Their capabilities of being able to ingest that kind of data overnight allowed us to come in the next business day, in our case, the next day, including weekends, right? I'll get to that in a second, that we could then get to work on these patients after they did these massive uploads for us. So thank you to Blue Sky for only 80,000 patients a day. Next slide, please. So Palm Beach ACO successfully reported on, about 233,000 patients across over 400 different practices, primary care, multi-specialty, and specialty. It covers the three measures. We had a ton of gaps, as you can see up on the screen. The most difficult one by far was screening for depression, which TJ may be able to cover in a little bit more detail. A challenge that we had, and maybe you have the same, is maybe your practices aren't all on the same platform. We had over 72 different EHR systems. We have an EHR team, by the way, and this was a significant lift, even for our experienced team. And there's also a lot of noise in the data. Having data is awesome, but you can use it incorrectly, or it can be a little bit distracting. And so, a great example is that a practice may be billing an I-11-9, which is, hypertensive with kidney disease, versus the I-10, which is the essential hypertension. Now, you do not have to use the I-11-9 because it technically doesn't meet the specs, even though that's what they were intending to say, is that the patient was hypertensive. And the I-10 came from an outside provider. So you just have to be careful and use a partner that prioritizes through the information that is displayed to the quality team and the user, that you do not have to accept an I-10 from outside because it doesn't meet specs, and you don't need to report on the patient at all. So just know the more you connect and the more you have, there will be more noise. So it's important your partner prioritizes the right information for your review. Next slide, please. All right, so I wanted to say, and maybe it was best on the last slide, that PBACO had about 117,000 assigned Medicare beneficiaries in the Medicare Shared Savings Program. And when Jessica, TJ, and I logged in to look at the Medicare CQM file and saw that it was many more patients than that, we had a moment of panic. Like, where did these patients come from? Why are we being sampled on them? And Derek covered in one of his first slides that it's touched and Medicare fee-for-service beneficiaries. We got surprised actually more from the specialist groups and the multi-specialist groups, because they touch a lot of patients, obviously, throughout the year, but maybe they're not an assignable specialty. And so we don't see them on our assignment list yet. We were being told that we needed to report depression screening on all of those eligible patients. So that was just one thing we learned right from the jump, and we do not want you to wait that long to learn that as well. So whatever you have in your group, your reporting will be more than your assigned beneficiaries. And that's a really important point to note. And all of you have different makeups of your ACO. And so just maybe take a moment after this webinar and think about what that could look like for you. Also, I believe the Medicare CQM file for Q1 is probably available. So you may want to look at that now, download that immediately and take a look at what that looks like to give yourself an idea. So some lessons learned, review and CPT2 codes. So CPT2 codes and HCPCS codes, educate and automate. That's what we tried to do as when those claims come through, which Blue Sky processes for us, BCDA also, that it will close the gap if it's the appropriate CPT2 code. So we thought that that was a low lift, low cost way for the doctors and the ACO to close gaps to take care of like this large volume of quality measures that we needed to report on. But to our surprise, and it does make sense, some of our groups that had Medicare Advantage experience, they were over 50%, even 60% of their gaps were closed from CPT2 codes because they were doing it already for their other payers, more specifically Medicare Advantage. So think about your population, and those practices may already be ahead, which is really great. And it's important to establish connections. So I'll share a couple of ours. We had and have connections with some of the major national labs like LabCorp and Quest. We're working on some additional ones, which TJ will give a little light into. The HIEs, where you get your ADTs, those vendors or state programs, maybe there's a diagnosis that comes in through an ADT that's actually an exclusion. Blue Sky can ingest and process all of that in the logic that they have built in, and that can really help appropriately reduce your denominator for reporting. And you do want to look for that when you have such a large volume, or even if it's just your first year doing Medicare CQM, those exclusions that meet specs are very important. And short-term connections and files like QRDA1s and MIPS dashboards, which are EHR-based files. And then long-term could be things like APIs, and there's a variety of those. Review your practice documentation early to ensure the discrete fields are being used. So you can educate them, you can install templates, but if they don't use it, it doesn't work. So when you pull these files, we learned this the hard way through depression screening. They were doing the depression screenings, maybe on paper and scanning them in, or maybe they're in a section over here, and they were not using the discrete fields in many cases. And if they didn't adapt to CPT2 codes, that left us with some gaps. And I had to really lean on those cues with hints from Blue Sky to be able to reach our 75% completion threshold. Next slide, please. And I'd like to introduce my colleague, TJ, our VP of Innovation.
Thanks, Amanda. So my name is TJ Leach, VP of Innovation here at PBACO. My role, like all of you, is many different hats, many different things that we work through. A couple of the big highlights is I oversee our EHR EMR specialists. So those are the folks that work on doing clinical workflows. They work on doing template installs. They're also kind of the point of getting some of the data out of the EMRs. I also oversee the ACO REACH contract. And then before working for PBACO, I was with an ACO management company with 6 different ACOs with the traditional quality reporting that we're all really used to. Blue Sky is great, and Amanda and Jessica are absolutely experts in all things quality reporting. That does not mean we didn't have a lot of challenges moving to this new model. Our hope is that we took on some of these, we figured out some of the nuances, and it's going to help everybody else, and it's going to help Blue Sky be a little bit better. A couple of highlights that we want to call out are the 72 unique EMRs with some inconsistency around our data structures. One of the big things that we saw is that even when documentation was happening, that documentation didn't always flow to the EHR data pools. It wouldn't always flow to the QRDAs. It wouldn't always flow to some of these dashboards. And we had to try to figure out how to work with BSA so those didn't automatically become fails. Amanda mentioned we have specialists with different types of workflows. those are really big discrepancies, especially with some of what they can report. So Amanda talked about how their eligible encounters would trigger on patients that didn't have an eligible encounter with our PCPs. Another big thing that we saw was how they would use, some of them would use failing CPT2 code for something like depression screening, which we had to kind of work through and adjust our logic. I think we adjusted that logic about 3 weeks left before submission go live to make sure that those weren't counting, that those weren't going to count against us. And then you guys know the CMS specs have been very unclear as we've been working through. The answers have been changing. The requirements have seemingly gone and changed on us as well. And then data gaps that what we're seeing in our claims, we don't get all of it. So that's something we had to work through and was a big issue for us for 2024. So we tried to start as early as we could. And you know, early in 2024, we decided to try to push our practices to get our CPT2s into the claims, tried to get them automated within the workflows. So within the EMRs that would allow it, we created automation to try to get those CPT2s to flow based on the results that were entered into the EMR. Those would then flow directly into Blue Sky via our CCLFs. And that helped us kind of early on figure out how many gaps we had and how much we'd have to manually enter. We got increases in the CPT2s, but if anyone who's done any work with kind of MA, you know, the CPT2s don't get you all the way there. So we did see a noticeable uptick, but it didn't get us fully to where we needed to go. So good starting point. And then we supplemented with some of the EMR data before eventually we went on to to the manual reporting. When we were doing no, Derek, you're good for the next one. Sorry. We did kind of current state. We were doing a lot of the QRDA1 polls and using that data, pushing it through Blue Sky and getting the results. The future state is trying to work with the EMRs directly and getting more direct APIs. So one big takeaway that I have on this is kind of this can be a little bit of a daunting task, or a daunting task to even get some of these QRDA ones out. Some of the EMRs, they wouldn't pull correctly. They wouldn't, we'd run into errors. They wouldn't pull at all. Our experience has been that the EMR vendors are starting to come around to working with the value-based care companies, with ACOs, and trying to do more direct integrations. So we're hopeful that those are going to lead to easier outcomes and easier pulls, be able to reduce our list quicker. It's not going to change. I will say in caution, if the data is not going to flow from the QRDA1, it's probably not going to flow with these APIs. So we're not expecting this to be the end all be all, but we are hoping that this kind of decreases the turnaround time between when we're able to get the information and then when we're able to start the manual, some of these manual processes, and, you know, having Derek and team work through where we're seeing additional opportunities from our claims. We have Quest LabCorp. We're expecting to expand to additional. And then one thing that we're really looking into is using preferred providers and providers not in our ACO to try to get some more information, especially around the new measure of breast cancer screening. When it comes to figuring out how to get this and to scale it correctly, I'll start with kind of the bottom, which is the differentiating factor for us with Blue Sky was a lot of vendors can link the data and can tell you, hey, this QRDA1 has a gap or this dashboard has a gap and it's a fail. Blue Sky, because of how much they've worked with the ACOs, really know what other pieces of data to look at to find those additional passes and to potentially pull that pass or that fail into a pass by looking at what else is happening around the care of that patient. Couple of things that we're looking at for this year and that we expect are going to help is a little bit more of using the structured data fields and a better understanding of what is going to cross into the EMR polls. So that's something that we're actively doing, especially around the new around some of our new measure of the breast cancer screening. We've been pushing for quality improvement year round. So now that the system is live, we're going to have access to it much faster and, be able to do some closures as the year goes on. For us, and, what I'd recommend, whether it's with Blue Sky or with somebody else, is work with a vendor who's going to listen and adapt to what you have. And then one really big lesson learned is we had some false failures from the CPT2s from some of our specialists that I had mentioned earlier. That one I wish we caught a little bit late in the game, but luckily we caught it before the performance here ended up wrapping. The reporting ended up wrapping. And then these are the 4 measures. Everybody on here has probably seen these. My one takeaway is that we're expecting there to be a 5th measure as early as 2026, and it seems like CMS is not letting up on how many measures they eventually are going to add. So breast cancer screening is new for 2025. Unless something changes, we're expecting colorectal to be available for to be added in 2026. And I personally expect they're going to continue to add. So trying to figure this out now, getting with a partner now who can get you where you need to go is extremely important.
Mm-hmm. Thanks, TJ. Yeah, well, one thing I want to point out too on the goal for 75% data completion is that it's per measure. It's not to accumulate everything together. It's like each measure has to hit that 75% threshold. And Medicare knows this is a beast. There's a lot of data out there, as Amanda said, and TJ alluded to, that it's not just your assigned patients, it's not just your assignable, but it's any patient with a qualifying visit during the year. Now, Medicare says that their rule is that what's suitable and technologically feasible to have correct, complete, and accurate data to meet the measures. So what that means is that if you have this data out there, you have to remove the noise, and that's a lot of what Blue Sky can help you do. Is when we aggregate data across all of your ACO practices, all of your data sources, we match and deduplicate your beneficiaries. We validate the numerator and denominator data. I'll get into a little bit more of some of the tools we have there. And then we actually prepare the final, it's called a JSON file, but we prepare that for you to submit to Medicare into the QPP site. So we try to make it as easy as possible. The biggest thing here is the data expertise. It's the prioritization. We can get a client up in about 2 to 3 weeks from when we have all the data. So there is time for the rest of this year to, enroll, sign up with Blue Sky, give us a call, and we can build a portal, and you have enough time, for us to get all your data in there to report for this year. And to get it up before the year's over so you can close gaps. But the most important thing on this slide to me is the data expertise, is the prioritization, because there's so much noise out there. And what do you focus on? We will continue to monitor and support you with gaps in care report, audits, quality checks. We've automated quality checks in the system. One thing I wanted to point out is the Medicare CQM report. That's just year to date. So when you get your Q1 report, that's just 1 quarter of the year. You will get your 4th quarter list in February of next year. And I think the deadline's March 31st of that year. And so you need a data expert, an analytics provider that can really load the data very quickly and expeditiously for you, so you can get working on that new set of patients that just came in halfway through February of the following year. So that's something very important that I don't think it's a great way that Medicare has it set up, but we work through it. And compliance and accuracy, it's very important. True, accurate, and complete data is very, very important. We take that very seriously. We help you assure compliance with your reporting. I want to give a couple of screenshots so you know that this isn't just vaporware, that we actually are a trusted provider that has good software. And it's a little small, but you can see that we have a dashboard that you can see a snapshot of where you are at any given time. So you can see who's eligible, how many gaps are closed, what are your fail, what's your performance rate, and what's your data completion rate. Anywhere you see the blue numbers, those are hyperlinks that you can drill into. And so we have the second column of blue numbers is the quality collection queue. And what that does is that helps you prioritize your work. We have different ranking. We have a ranking system that are color coded that help you prioritize where you do have those gaps. And you can drill down into any of the patients. We try to give some information at this screen level, so you can see maybe the most recent HbA1c for the work queue for diabetes. But then you can also see the measures that are incomplete or skips or passes for the patients in this view. Now, I want to just let you know that this is fake data. These patient names are not real names. This is from our demo database. I just think it looks better when things aren't blacked out. You kind of get a better idea of what you're looking at. So in this work queue, we generally speaking, there's a lot more data or a lot more logic in the background, but generally speaking, we prioritize the assigned PCP data. So the PCP that the patient's assigned to. Then we also prioritize the participant data, somebody that's a PAR provider within the ACO. We also then prioritize patients with missing numerator data where there's hints. So we look at all the lab data, all of the claims data, BCD, all of these data sources out there, and we use them as hints where we'll say there may be missing numerator data, but for example, there may be a lab CPT code that says their HbA1c was done on this date in the CCLF, the claims data, but there's no HbA1c lab result found in the Quest or LabCorp interface or whatever lab interfaces you want to use. We're lab agnostic, so if you have a lab you use, it's all the standard results. And then finally, we have a queue for fails, so you can look by assigned PCP. Sometimes we have data mismatches. The EHR data may say one thing, but the CCLF data says another. The lab data may say a third thing. And so we help organize all of this so it's actionable for you and it's clear to you, so we can make your job easy and achievable through navigating through these big quality changes. And we'll close gaps. That's one of the reprieves that you have in this, is that it's not like the web interface reporting where you have to have that document. You have to have that documentation that says something was done. You can use the data to say this is, as long as you can stand behind it, you can use the data. So if there's a CPT2 code, as TJ said, that was submitted that says it was passed, we'll consider that a pass. So you can check that off, and that's why that strategy works. The HbA1c strategy works, getting that lab data. Also, here's an example of an incomplete one where a patient, but we provided a hint. So you see that the status is incomplete. We prioritize the hints. So you can see that the annual wellness visit depression screening was done. You have a link to the claim, and then you can drill down and see what happened there. You can also work with the PCP if you need to say, okay, well, on May 30th, I need to see the result. Was the follow-up plan done? Something like that. We also put other encounters in here where we find CPT2 codes or CPT codes where there's encounters where it might have been done. And then we explained why we rank this particular patient in this queue. We say, well, the depression screening was billed, but we don't have a CPT2 code. So this is like a low-hanging fruit. Maybe we can just close this measure pretty quickly. Now at the bottom, you can close it in two different areas. Is the patient qualified for this measure? If you say yes, then it's just a yes or no. Was a depression screening done, and was a follow-up plan documented? And you hit yes, and you can save it, and that measure is closed. We have some additional tools where you can make notes. You can drill down into the specifications. you can go right to the patient profile. So Blue Sky has a complete patient profile where we aggregate all the data, all the labs, all the HR data. And it's just like a patient chart where you can go through the different tabs and look at the claims, let's say, or look at, different services provided or different diagnoses. And you can also upload the documentation. So if you wanted to put that documentation in there on the depression screen, the PHQ 9 or 2, you can just upload it here if you choose to do it that way. So we have a lot of flexibility in the system. Same here. This is another pass for Prep 5. So we don't have we have the claim from the radiologist, and then we also have the primary care doctor confirming that the breast cancer screening was done. So no further action needed. This is just another example of how that works. And then, so here's an example of a breast cancer screening where it wasn't done, and it's a fail because the physician in this claim up here indicated that it was a measure fail, that there was a that the report was not reviewed. But let's say upon review, you have two options. You can confirm it and say it was if you review and you found that documentation. You can confirm it as a fail, and it'll close it out. So that'll add to your data completion. Or you can just mark it as incomplete, and then that will not count towards your data completion, but it won't count as a pass or fail either. You can alternatively, that's a quick way to do it. You can also go through and answer all the questions and put the information about when it was a breast cancer screening done, in a particular time frame. So those are just some screenshots just to show you, some of the ease of quality reporting. When you look at these views, each patient has 4 tabs. So it's a skip sometimes if they don't have diabetes, if it's incomplete, a fail. And pretty much every patient needs a depression screening and breast cancer screening. Those are 2 where you can start to close those gaps quickly. It's a very good idea to start now if you haven't already. So that takes to the next slide. So there's not much time left. We feel we have excellent software that can really help you because it's so easy. We can bring a portal up in 2 to 3 weeks. Once we get all your data, we'll work very closely with you. There's 475 ACOs that are in the same situation or similar situation you are. And one thing I will say, across our clients, we have very large clients like PBACO, but we have, ACOs as small as, 6,000 lives. So we work with all types and sizes of ACOs and all different types of situations and levels of data integration. And we work very closely as a boutique with those clients. We have a lot of happy clients. Here are just a few of them. And, we'd really like you to reach out to us. We are a trusted partner of Palm Beach ACO, one of the most successful ACOs in the industry since inception of the ACO program. And so please reach out to us with any questions or if you'd like a demonstration of the product. Thank you.
Thank you for that presentation, Derek, Amanda, and TJ. We do have one question. We had a few, but I saw that Jessica was able to answer yourself, Derek. One of the questions that just came in is why is Palm Beach reporting Medicare CQMs instead of MIPS CQMs? For MIPS CQMs, you'll only need to achieve less than 90% performance on an A1C and more than 40% on blood pressure control. In contrast, Medicare CQMs require over 67% performance on measures number 236, number 134, and number 1112, and less than 33% on measure number 1. I'm not sure who wanted to take that if you had an answer.
Jessica can chime in. From our understanding, MIPS CQMs may be all payer, and Medicare CQMs is on the Medicare. And so with our challenges of 72 plus EMRs and future integrations coming, it seemed it was the best option for us to pursue the Medicare CQMs on the population in which we're used to reporting on. Jessica, any clarity you'd like to provide on my statement?
Yeah, I mean, yeah. Your volume, sorry. So typically PBACO historically does very well in terms of our overall quality scores. So we're pretty confident that we'll be able to obtain the necessary thresholds to meet the performance rates needed to obtain shared savings.
So I think PBACO has reported on 233,000 patients for 2024. I'm pretty sure you would be well over 500,000 if you included the commercial patients. No?
That sounds like a lot. I think we're good with our plan for now.
Yeah.
Thank you for answering that one. Another question that I had is, how does BSA help practices effectively track and implement CQM performance measures throughout the year?
Oh, it's it's available. We have been reporting on the web interface measures throughout the year too, for quite some time. And we have performance dashboards. So we collect data real time. So every time we do a CCLF load or the BCDA, the weekly claims data comes in. We have lab integrations come in daily in some instances, weekly as well, data dumps. So actually, it's not unusual to have Blue Sky clients working throughout the year on CQMs, and they use the module with the work queues and monitor and close gaps. And we also have within Blue Sky, like I said, gaps in care report. And so it's just a great idea to get the depression screening gaps out, breast cancer screening gaps out. When it comes to diabetic and hypertension, those tend to be later in the year when patients have visits towards the end of the year. But you can certainly close those close gaps now if the patients are healthy and they don't come in too often.
Thank you for that, Derek. One last question for you all today is, what hints are available in BSA to help improve the practices and ACO's quality score?
Mm-hmm. I mean, we have all types of hints from measure compliance to say that something was or was not done, as well as supporting claims data, lab data, health information exchange alerts, things like that. And we populate them and we organize them into, this is helpful for this measure. For depression screening, on the screen right now, we'll have the last wellness visit or depression screening that we see there. We'll have the last 3 encounters from the assigned TIN. If we don't have any from the assigned TIN, we'll have the participant TIN. So we try to put this information up there so you can find helpful information that may contain some of the answers that you're looking for if you don't have it in those areas.
Thank you for that, Derek. Is there anything else you'd like to add to our audience today?
Don't wait. Don't wait. I can't stress we're a trusted partner, and it's just I can imagine being in a position where, how do you know this works? How do you know it works for me? Are they going to do what they say? And give us a call, and we'll show you. And we'll meet with you so we can understand your ACO and your physicians a little better.
Well, I want to say thank you to Derek, Amanda, TJ, Jessica for joining the call today. Thank you to Blue Sky Analytics and to Palm Beach ACO for sharing your insights and expertise with us today. Thank you to everyone who joined us for this informative session. As a follow-up, we'll be happy to share an email that includes the presenter's contact information. Should you have any additional questions, along with a link to our webinar recording, please feel free to share that recording with your colleagues, your peers, whoever may find it valuable. We appreciate your participation and encourage you to keep an eye on your inbox. As we have officially announced, FLACO's fall conference registration is now open. It's taking place October 22nd through 24th back at the JW Marriott. And so we hope to see you all there. I know we'll have Derek probably on a panel speaking again because he loves to speak.
Yeah, well, thank you to you, Sam, and Florida Association of ACOs. You guys are a fantastic partner, and we appreciate you.
Awesome. Well, you all have a great day. Take care.